Testing.
Dr. Wilson, President Wilson, and I can't remember what.
Good evening, ladies and gentlemen. Welcome to our third annual Dean's Lecture Series. I'm so pleased that so many of you good folks were able to make it here. I thank you so much for being present and being available for our meeting. I have a list of people that I need to call out and recognize. So I do have my cheat sheet here. Hope you all didn't think that I was going to memorize all these names. So let me start from the top. A special welcome to my wife, Violetta Jones. I always wait to do her last. I'm doing her first today. Okay. Chair of the Board of Trustees, Dr. Richard Bond and his lovely wife. President Wilson and his lovely wife, our First Lady. You stepped out on me. Okay, that's all right. Our Provost, Dr. Googlechuck. Dean for the College of Osteopathic Medicine of the Pacific, Dr. Paula Crum. And of course, I'm glad I looked right next to you because I didn't have her name on my list. The one and only Vice President of our board. Don't let me you know I was going to do that, Linda Kranz. Sorry, Linda. You know I love you. Dean Stephanie Boland, Dean of the College of Allied Health, Dean of the College of Pharmacy, Dan Robinson. And some special guests that we have. First, Sylvia Girardi. She's the Special Assistant for Community Affairs. Mr. John Patton, General Counsel for Charles Drew University. Bill Shea, the Assistant Provost for Charles Drew University. And Professor Kiyoshi Parthalo. Very good. I actually made it through that, but only stumbling once, so I'm very happy. Hopefully everybody up at the Northwest Campus can see us well. I know I'm not going to be able to see you from here, but... You're on the copy. Oh, I'm sorry. Just like my good buddy, Dr. Harkless, huh? Dean for Graduate Medicine, Dr. Beaudry. And I must recognize one other special person that I'm looking at currently right now, and that is our Professor Emeritus and Dean Emeritus, Dr. Lawrence Harkless. I did get everything. Well, welcome tonight. I'm hopeful that you all are going to enjoy this lecture that's going to be put on by a very special guest, an individual that I was privileged to actually go to his investiture some 7 years ago. I've just found out that it's been that long already. This is Dr. David Carlisle. Dr. David Carlisle will be talking to us tonight about Sisyphus and the sailboat. So who in here did not review their Greek mythology? Let me see a show of hands. You did not or you did? Oh, shame on you, because there's going to be a test after this. It's a 10-point quiz. It's going to count for a grade. No, I'm just kidding. All right. Without further ado, please help me join me in a warm welcome for Dr. Carlisle.
Lester, thank you. All right. Well, good evening, everyone here at Western University of the Health Sciences. It's a pleasure to be back. I've been on this campus I don't know how many times, both before and since becoming president of Charles R. Drew University of Medicine and Science. So it's always a pleasure to be back, and indeed I was here last night for the wonderful and very moving memorial service for the founding president, Dr. Philip Pomerantz. Somebody I worked with and got to know very closely, welcomed me very, very warmly to Los Angeles when I came down here from Sacramento, where I'd spent 11 years up in state government. I will put out a wave to everyone in Oregon. My wife is a Portlander, and if I didn't acknowledge the wonderful state of Oregon, she would not be very happy with me. So all that said, it's great to be here. Let me grab my remote. Thank you very much. And so what we're going to talk about tonight is healthcare reform, something that has been near and dear to my heart, but also my mind, since I formerly studied it as a student and professor at UCLA, and hopefully we can have a great discussion about this. But you're probably wondering about the title. When you think about Sisyphus, the image does not seem that compatible with a sailboat. How many of you are sailors, by the way? It's always interesting to me that when I ask that question, hardly any hands go up. Seriously, nobody's a sailor here? Nobody? Windsurfer, anybody? Okay, well, we're not exactly in Florida, are we? And we're not in Annapolis either, places where more people are more likely to sail sailboats. But anyway, think about your 16-footer, 18-footer, maybe a Hobie Cat or something, and the idea of a massive boulder and the sailboat. They just don't go together. This will not become clear to you until the very last slide of the presentation. So stay tuned. We'll cover Sisyphus earlier. But really, the subtitle is The Course Toward Universal Health Insurance in the United States, a very important topic today, and one that is very timely, obviously, as well. Let me say a couple of disclosures. And so this is the usual speaker conflict of interest statement. And what I usually say is, it's a nice statement, but it's really not true. Because as an American, I and we all have a vested interest in this topic. Virtually all of us are taxpayers one way or another, and so we have skin in the game when we talk about any type of massive federal, state action involving government. So one thing I will say is I'm not going to be talking about any devices or drugs during this lecture. Well, maybe one. We'll see what happens. I wanted to start with an important quote here. And that is, of course, something we've heard President Obama say. The arc of the moral universe is long, but it bends toward justice. Because what we're talking about here is justice, social justice, moral justice, in a way that will become clear, I think, down the road. But this quote, I think Barack Obama and others may have attributed it to Martin Luther King, but it's actually from somebody named Theodore Parker. Anybody know who Theodore Parker is? Anybody here from Connecticut? Theodore Parker was I believe, an early 19th century abolitionist from the state of Connecticut. And he's the one who first issued this quote. The reason I use it is because I think it sets the tone for my perspective when we talk about health insurance reform. I'm from a family, I grew up in central Los Angeles, went to elementary school in Los Angeles, originally born in Virginia, and I think my experience in the healthcare system turned out to be different from what I consider to be kind of normative. I mean, when I was little, I used to think it was normal to sit in a waiting room with 50 other people, waiting for hours to see the doctor. And things like this. I have relatives who have been dependent upon the county healthcare systems in Los Angeles, living in communities like Compton. For me, this topic is very personal and very visceral. And I think it speaks to the moral challenge that's facing all Americans, because I've definitely had relatives who've not had health insurance. I've had relatives who've suffered because they couldn't see the doctor. So again, this is a personal topic, and I think it's a topic of basically moral righteousness for the United States. It's that compelling. But since I'm here in the front of the room, I'll just digress for a few moments and put in some advertising for our university. Charles R. Drew University of Medicine and Science, so just bear with me. Yes, we are the Mighty Lions. We got into trouble with Loyola Marymount when we picked this because they are the Lions. But we promise never to play D1 basketball against them. We'll see about that. Our namesake is Sylvia Drew Ivy's father, the distinguished Dr. Charles Richard Drew. Many consider him to be the father of modern blood banking technology in the United States. basically helped with the war effort during World War II, later became the chair of surgery at Howard University Medical Center. An important thing about Dr. Drew, though, is that there's an end-of-life myth that pertains here, which is that he was driving from D.C. to Tuskegee, Alabama. The car went off the road. He suffered grievous life-threatening injuries, and that's when the myth begins. He was taken to a small, segregated rural hospital in North Carolina, and the myth is, at that point, that he was denied care, even embellished further by saying he was hemorrhaging to death, and they refused to give him a transfusion. We have attestations at our university from doctors who were with him in the car, none of which were significantly injured, except for maybe a broken arm. And basically, Dr. Drew was already well known as a medical celebrity during that time. The doctors in the emergency room recognized him. They knew who he was, and they basically did everything they could to try to save his life. But he had, among other injuries, a transected superior vena cava, and some other injuries, and even today, probably, we would not have been able to save his life. So that was the end-of-life myth involving Dr. Drew. Our namesake, and somebody who set the bar really high for excellence in healthcare. Our university, Charles R. Drew University, is 51 years old. We are a health professions-focused university, very similar to Western University, with one nuance, and that's that we have undergraduate programs at our university also. Our school is noted for our primary care focus. About 2/3 of our College of Medicine graduates go into primary care specialties. About 40% specifically go into family medicine. We were recently ranked number 2 in the country among all private 4-year not-for-profit universities in terms of student diversity. Our students are much more likely to go into practice in underserved areas. We have a very, very successful NIH-funded biomedical research program. We have well-known programs in the pipeline category, such as our Saturday Science Academy, featuring students as young as age 4 all the way through high school. And we also have an international presence in countries like Angola, Rwanda, historically in Belize, Jamaica. And that's basically our university. You can read our mission statement. Our vision is excellent health and wellness for all in a world without health disparities. And a couple of key words in the mission statement that you will see are words like social justice and health equity. And it's those phrases that allow us to be a magnet for students that want to go into the health professions who have a similar personal focus. And our students will tell you that that mission statement is what brings them to the university. Here's where we are. We're right in the heart of what used to be called South Central Los Angeles, what's now called South Los Angeles. To the right, you see the Watts Towers made by hand by this gentleman, Simon Rodia. And we are in the basically in the middle of what's called the Watts Willowbrook community, right below the 105 freeway. This is kind of a formative photograph. This is during the Watts Revolt of 1965. It was the McCone Commission report that tried to diagnose the origin, that really identified the origin of that revolt back in when the report came out in 1966, that basically called for the creation of our university, along with the LA County Martin Luther King Medical Center. And this is a street in Watts during the curfew. This is another image, again, from the same revolt. And many lives were lost, our community lost many buildings during the event, and but this was really I think a single cry, shout even, for services, healthcare services, education services, and it's still a challenge in our community. We'll speak to that in a bit. But another way to define the community is in terms of what's called service planning areas. And this is how the LA County Health Department divides the county up for healthcare planning purposes. We are currently in SPA 3 out here in the San Gabriel region. But the university, our university, Charles R. Drew University, is in SPA 6. SPA 6 has a population officially of just over 1 million, unofficially probably about 1.3, 1.5 million. And the interesting thing there is that that population is bigger than the official urban populations of all these cities. San Francisco, Seattle, Honolulu, Portland, Again, hello, Oregonians. Boston. And I'd like to specifically point out Boston because how many medical schools are there in Boston? I think it's 4. Last time I counted, might be more today. How many teaching hospitals are there in Boston? I wouldn't even begin to offer a number. How many teaching hospitals are there in SPA 6? 0. How many medical schools are there in SPA 6? 1. A stark difference. And so it's no surprise seeing that the health statistics for the SPA 6 area of Los Angeles are among the worst in LA County, the entire state of California. It doesn't matter whether you're talking about infant mortality, maternal mortality, life expectancy, preventable hospitalizations, amenable mortality. Sometimes these differences are 3 or 4 times the LA County average. This is still a starkly under-resourced, underserved area in terms of healthcare. Okay. Enough for my free advertising. Thank you very much. Let's get on to the presentation. What is a wallet biopsy? Who can tell me? A wallet biopsy is what happens when you're walking across that street that we just crossed, Mr. President, on the way over here. And instead of stopping like we did for the light to flash, we kind of kept going. And next thing you know, you're waking up in the emergency room. They've already done the wallet biopsy on you. The wallet biopsy is typically the first procedure you ever get anytime you see the doctor. And you have to have one of these things in your wallet. And I hope that all of you do. Health insurance is a requirement here at Western University. So nobody should have any excuse for failing the wallet biopsy. If you fail it, things can turn out very differently for you. You may not get anesthetics, analgesic medication when you need it in the emergency room. We know that that odds of doing well in procedures are different. If you fail the wallet biopsy, you may wake up in a public hospital when you started out in a private hospital. Everything pretty much in the healthcare system in this country is dependent upon successfully passing the wallet biopsy. And that's not necessarily true in any other industrialized nation in the entire world. So I will now tell the tale of 3 patients. These are all true stories, and they go back to my training and career as a physician. The first is a story about a gentleman who sang as part of a group, Under the Boardwalk. Anybody heard of that song, Under the Boardwalk? The original Drifters. And I encountered him one night when I was on call. He wasn't really my patient, but I was covering. And I knew he was there. I went in to talk to him. It was like probably maybe 11:30 at night. And we were talking and chatting, very wonderful person. And he was later to die during that hospitalization. And it struck me as an intern that it was just amazingly ironic. Here's a true American icon who had contributed to the very kind of structure of American culture with his singing career. But he was spending his last days in a safety net hospital because he was destitute and had no health insurance. And it just shaped me profoundly to think that this is how our society treated basically American heroes. The next story also had an unfortunate ending. I first met this gentleman. He was, I think, about 18 years old or 19. Again, I was an intern, this time in the emergency room at Harbor UCLA, where I did my internal medicine training. And I saw him for an STD, and I chatted with him a bit and assumed I'd never see him again when we discharged him. A few years later, here I am, chief resident in internal medicine, and I got a call from the attending in the emergency room. Dave, there's a patient here who's asking for you. And I said, oh, really? Okay. Asking for you by name. Oh, okay. What's his name? Really? It's him? And I actually did remember him. And the attending said, yes, and the news is not good. He's here with multiple lung metastases. And it looks like it's metastatic testicular cancer from everything that we can tell from what he's told us. And I said, really? That's okay. I'll come down and talk to him. Let's say his name is John. Walk down. John, what happened? You know, you have metastatic cancer. How did this happen? And he said, Dr. Carlisle, you know, I couldn't really share this with the other doctors, but I can share it with you. I knew something was wrong. I felt a mass, and I was afraid it might be cancer. So I knew I had to see a urologist. And so I made an appointment, went to see a urologist, and they said, well, this is very early. Don't worry, this is curative. We can usually prevent this from becoming life-threatening. But then they asked me, do I have health insurance? And I said, no, I'm uninsured. At that point, they stopped caring for me, and I didn't see them again. And I didn't know what to do, didn't want to come back to the public hospital. I was afraid, basically. And then finally, I couldn't stand it anymore. I was getting symptomatic, and here I am. He died from his metastatic disease just a few months later. But in the meantime, all the residents at Harbor kind of banded together and found some malpractice attorneys to represent him. And even though he's no longer alive today, we were able to fund not just the sustenance of his family, but to put his kids through college based on the malpractice settlement that his family received. The third story has to do with a patient I saw at UCLA. And I was an attending in clinic, and it was around 12 o'clock, and all the house staff were off heading to lunch, and I was just kind of hanging out just to see if anything was going on. And our charge nurse came up to me and gave me that look, like, I said, you know, I know what this is about. Then she said, Dr. Carlisle, could you just see one more patient? And she gave me the look again. The look was code for forget about lunch. You're going to be here for at least the next hour. Okay, I got it. That's part of my job. So I walked down the hallway, and as I'm getting ready to turn the corner to go down to the room where the patient is, I knew what was wrong with him. Based on my days as a county resident, I knew what was wrong with him. I was using one of my 5 senses. Who can tell me what was wrong with the patient? So I walk in the room, didn't even have to look at him. I shook his hand and looked at him in the face. Didn't look at his condition. I said, sir, you've got to have your leg amputated or you're going to die. And he said, fine, I understand. I know what's wrong with me. I know what this is. And the reason I'm here is I heard this wonderful radio campaign, advertising campaign that you all are conducting about having the best hospital on the West Coast. And I just wanted to get the best care possible. And so I decided to come down here all the way from Oxnard to be seen. I said, fine, no worries. We'll take care of it. You know, this is the type of thing we deal with all the time. But first, there's one other person you've got to talk to. Call the patient services representative. She came down, she walked in the room, she walked out. 5 minutes later, she didn't even talk to me. She just looked at me and shook her head. I went back in the room. I said, sir, we can't take care of you. You don't have health insurance. We could take care of you, but you'd have to put up a deposit of, and I think it was about $25,000, cash deposit. Seriously. And I said, but, I trained at a hospital right down the street, county hospital. I'll just call one of my friends there, and they'll take perfectly good care of you. He said, fine, whatever's necessary, I'm ready for it. Got to lose my leg, I'm ready for it. I thought I'd never see him again. About 3 weeks later, I got a phone call from him. And he said, Dr. Carlisle, thank you very much. I'm probably alive today because of what you did for me, sending me to Harbor, UCLA. Yes, I lost my leg, but I still have my life, and I'm forever thankful. These 3 stories obviously have one thing in common, which is every patient suffered from the lack of health insurance. Okay, I apologize. This slide may be offensive, but this is a copy of an original 35 millimeter film slide back in the days when we used to use real slides, 35 millimeters. And I had a copy of the slide and I lost it. And the only reason you're seeing this today is that I put out an email quest all around the country, and finally somebody in Florida said, Dave, I have a copy of the slide. I'm going to send it to you. So here it is. It's a perfect metaphor for the American healthcare system. You all are healthcare people. How many of you have ever seen this patient walking the hallways of the hospital just like this? It's why I always tell my patients when they're admitted to the hospital, when they give you one gown, always ask for two, because you don't want to be in this position. Now, he was fine. He's perfectly oblivious to the fact that, he's looking at himself, he thinks he's got great coverage, right? But the point is that he can't see himself from another perspective. Because if he looks at himself from afar, from a different perspective, all of a sudden it becomes quite evident that he's got, and I apologize, huge gaps in his coverage. And this is the metaphor for the American healthcare system, because it's true, if you're well insured, this is the best healthcare system in the world, absolutely. You can get everything that you need in this country if you are well insured. But if you're not well insured, forget about it. Whether you are a 19-year-old needing a cardiac transplant or a 64-year-old with diabetic gangrene, you're experiencing the huge gaps in our healthcare system. I apologize. I know that the print is fine here, but I wanted to get every OECD nation, Organization of Economic Cooperation and Development nation, on this slide. And look at this. The right column is the most important one. Percent of the population not insured. 0, 1.3, 1, 0, 0, 0, 0, 0, 0. On and on until you get down to Mexico, 17.5. Okay. Mexico has some opportunities. The slide doesn't quite fit in the bottom. Turkey, I can't talk about Turkey, but 32. Everyone else is 0 except for the United States. At the time of this data set, the United States had 18% of the population uninsured. The question is, if they can do it, why can't we do it? And with having large portions of the population uninsured, it's no wonder that we have bad healthcare statistics compared to other countries. And so here we have things like, and this is an old slide, life expectancy for men and women, infant mortality. These are percentiles across OECD nations. The bottom line is the United States does not rank at the top of any percentile list among the industrialized nations of the world in terms of healthcare outcomes. It would be too simplistic for me to blame all this on uninsuredness, but to be sure, it's a major factor. Again, maternal mortality. Leading this pack is Sweden. Japan is also very low, many other countries. Our maternal mortality rates are, in this country, several times greater than other industrialized nations. Another slide, just another metric, percent of doctors who report spending time getting patients medications. When I'm seeing patients, I need to know what kind of health insurance they have so I can know what kind of medications to give them, because drug X may not be on the formulary for one patient, but it is on somebody else, and I've got to handle all that stuff. Here is amenable mortality. And you see countries here, Switzerland, France, Austria. Amenable mortality is something that should resonate with all of us, because it basically is something we all strive to work against. Amenable mortality is death from conditions that are treatable. Death from things like diabetes, heart failure, things like that. It should be largely preventable, or at least it can be delayed considerably if patients can get good, effective health care. The United States does not do well in this metric. As you can see, other countries are well ahead of us. And just recently, Atlantic Magazine published an article about health systems performance. And here again, you see a host of OECD nations. And the United States was considered the worst performing country in the industrialized world in terms of the overall performance of our healthcare system. These are major issues. And this is why two California health economists decades ago, which is still true today, called the American healthcare system a paradox of excess and deprivation. You've already seen some of the deprivation slides. What about some of the excess slides? And this is where the irony of healthcare in the United States really comes home. Okay, health spending per capita among OECD nations. On the x-axis, you've got per capita GDP, gross per capita GDP. On the y-axis, you have healthcare expenditures per capita. And basically, there's an amazingly tight regression line between gross per capita income and per capita healthcare spending. That's pretty much true across the entire OECD nations until you get to the United States. And we're spending way more than we should be on healthcare given our per capita income in this country. As much as 50% more than countries like Canada or Belgium, for example. Maybe more than twice as much as Great Britain is spending per capita. But despite that expenditure, our healthcare statistics are at the back of the pack. Another way to look at this is this slide. And it shows that these countries, primarily in sub-equatorial Africa, but also around the world, on the far left, could drastically increase life expectancy by spending just a little bit more on healthcare. But on the other end of the slide is the United States, where we're spending way more on healthcare than anyone else. But other countries are beating us on life expectancy. I mean, look all the way over on the left, and you've got Singapore above the line. About 25% the per capita healthcare expenditures of the United States, but better life expectancy. There's something very wrong with this picture. And it's something that we're trying to work on. And again, it's why Richard Kronik and Alan Enthoven use the phrase, a paradox of excess and deprivation. Now, one of the big problems, especially here in Los Angeles County, is, of course, with a position that has the benefits, there is no salary. Quite literally true. I'm sure many of you have parents or know people who've been working 2 full-time jobs, 3 or 4 part-time jobs just to make ends meet, and they've not been able to get health insurance. And of course, there's this issue also. You don't know how lucky you are, a quarter of an inch either way, and it would have been outside the area of reimbursable coverage. Another paradox of our insurance system is that we try to exclude the very things that people need coverage for. If you have high blood pressure, historically, conditions that would be related to high blood pressure, like stroke, heart attack, could often be excluded from insurance, historically. So what's the solution to all this? Well, healthcare reform. Should be easy, right? You know, if all these other industrialized nations can do it, it should be easy for us to do. I mean, we tackle hard jobs and get the job done. I wish it was so easy, because healthcare reform is a politically intensive topic. And here you have a couple of examples of, I think, various types of healthcare reform, ranging from conservative to progressive. And typically, the more conservative approaches tend to cover less of the population without augmentation. I would say that the current Affordable Care Act is a combination of the individual mandate and employer mandate. But really, as you can see, just requires some enhancements to get to true universal coverage. But is also probably it's much more politically feasible than things like single-payer health care, like our Medicare program or what you've got in Canada, or socialized medicine, which is probably what I would call the system historically in countries like Sweden, and until very recently, Great Britain. But we've been trying to do this. This has been something that has been an undertaking in California for a long time. How many of you know about our immigration initiative that was on the ballot about 1994? That's Proposition 187. Well, in California the same year, a single-payer initiative qualified for the California ballot. It set a record for the greatest number of signatures gathered by an all-volunteer signature gathering force in California history. And despite polling positive in the early polls, went down to the worst defeat of any ballot initiative that I'm aware of in the state of California, losing over 3-1, which talks about the political saliency of single payer in California. We could talk about more on that later. Which brings us to Sisyphus. And Sisyphus looks curiously like, I think, Barack Obama, if I recall. Barack Obama. And the reason Barack Obama is Sisyphus here is you've got some, well-known American presidents: Teddy Roosevelt, Franklin Roosevelt, cousin, Harry Truman, Lyndon Johnson, Richard Nixon, Bill Clinton, et cetera, et cetera. They were all trying to push the boulder up the hill to get to the top of the hill to achieve universal health insurance. They all failed despite multiple efforts. I think Teddy Roosevelt was called a socialist, Harry Truman was called a socialist, Richard Nixon was called some other things, I won't mention those. It was only Barack Obama that actually got the boulder all the way to the top of the hill. And it required a lot of political engineering to do it. And even, I served in the Schwarzenegger administration. We had a healthcare reform proposal that would have created basically the Affordable Care Act in the state of California. We were polling really positive. We were ready for a bicameral passage in the legislature, and then the recession hit. And anything involving money was off the table. And all the people in the Schwarzenegger team, except for me, were invited to go to Washington and work on the Affordable Care Act. So, what happened afterwards? Patient Protection and Affordable Care Act. Nice picture, looks kind of like the weather outside today, right? A little bit cloudy, nice and sunny. Otherwise known as Obamacare. This is kind of a pejorative statement when it came out, but President Obama liked the phrase Obamacare, said, I think I'll call it Obamacare myself, and it kind of stuck. Basically, it became probably the most significant expansion in healthcare since at least Medicare and Medicaid in 1965, but obviously it was not perfect. And then we could talk for hours about all the elements of the Affordable Care Act. That's kind of a waste of time. I always tell people, just remember three things: insurance expansion, insurance reform, and safety net expansion. That's really what it's all about. Some details here: the elimination of things like, rescission in healthcare, the elimination of lifetime limits. I mean, do you all know that in most insurance policies you can totally exhaust your lifetime limits, including Medicare, historically? And then next time you go to the ICU, you're not insured, you're not eligible for health insurance. Or rescission, that your insurance can be canceled retroactively, and your bills can be applied to you retroactively when insurance is canceled retroactively. That was declared illegal in California under Governor Schwarzenegger, and in the United States under President Obama. My son was a beneficiary of the Affordable Care Act. Here he is, he's 24 years old, he's off his parents' policies, and under the ACA we were able to put him back on paternal policies, and then he turned 26, he was on his own, but yes, my own son benefited from the Affordable Care Act. Now the ACA came in for some major criticisms. Yes, too much government control, true. At least the government control part of it. Don't know about the too much part of it. Mandates, individual mandates. You have to have health insurance. Disrupting existing insurance policies. Now the advocates would say, but those policies probably weren't worth the money that people were paying for them. But also paternalistically, we've got something better for you. We do, and you have to do it. It raised costs for people with some insurance policies, to be sure. It eliminated flexibility in coverage by putting in uniform benefits. And yes, for the wealthiest, roughly 2% of American society, there were significant tax increases associated with the ACA. All these had resonance. My apologies for the fuzziness in this photograph, but just pay attention to the squiggly line. Don't try to read too much because this is a screenshot. This is what the ACA did. You can see a peak of around 18% uninsured around quarter one in 2013, dropping down to 11% by towards the end of 2015. The lowest percent uninsured pretty much ever in the United States. It's still 11%, it's not zero like some of those industrialized nations, but 11% compared to 18% or 20% is pretty good. And here you see some examples from 3 states, Arkansas, Kentucky, and Texas. Arkansas and Kentucky chose to expand their Medicaid programs. And under the ACA, states were offered a great deal. You expand your Medicaid program, and the federal government will cover as little as 90% and as much as 100% of that increased expenditure, and you don't have to cover pretty much anything. And states like Arkansas and Kentucky said, that sounds like a good deal to us, we'll take it. Texas still has said no, we won't really expand Medicaid. And you can see what's happened here. the number of people, the percent of the population in Arkansas and Kentucky that remained uninsured plummeted, mostly through the expansion of Medicaid programs. But in the case of Arkansas, private insurance also expanded. Texas pretty much stayed status quo, didn't change anything. But this just shows how stark and dramatic the effect of the ACA was on uninsuredness on states that participated fully, especially by expanding their Medicaid programs. Those expansions, by the way, are significantly associated with a reduction in unpaid bills, the amount of debt, reduction in medical bankruptcies. Healthcare is the number one cause of bankruptcy, personal bankruptcy in the United States. More people were getting their diabetes diagnosed and into therapy. People with behavioral health issues were getting care when they couldn't get care before. All these things were happening associated with the ACA. But still, some states did not fully participate. And you see the ones that did not expand their Medicaid programs at the time this slide was made. Interesting geographic pattern here, because it corresponds with the geographic pattern here, roughly speaking. These are counties in the United States. The green and blue counties are the counties where life expectancy has been going up. The counties with the red and the orange are counties where life expectancy all of a sudden started going down. In fact, in the last 2 decades, maybe the last 10 years, for the first time since the year 1900, when we started measuring this parameter, we saw a decline in life expectancy in the United States. It's predicted to continue for certain populations. Those of us that have gray hair, President Wilson, and President Carlisle, to be sure, we're told that our children may not have the same sort of economic drive and even life expectancy as their parents' generations in the United States. And a lot of it is because of this barrier of getting health care. Some of it is also related to things like the opioid epidemic in the United States, which also disproportionately afflicts the southeastern United States, where life expectancy has declined. Oh yes, back to amenable mortality. Under the ACA in the United States, amenable mortality did go down, to be sure, between 2014 and 2004. But the interesting thing is, it went down more in these other industrialized nations. I don't have an explanation for that, but they've been able to do more with reducing death from treatable conditions than we have, despite the implementation of the ACA. That's a pretty powerful statement. Again, this is why we all go into healthcare, so we can treat patients, so we can prevent deaths from amenable mortality. I mean, that's what it's all about, right? That's why we become every health profession. And then finally, there was this slide. This slide shows something very interesting that happened. The ACA really never polled positively among the American population. But just in the last few months of the discussion, it flipped. And all of a sudden, people started saying, well, maybe we actually like it. And this becomes relevant down the road. This is people saying, maybe, my son has health insurance. I can see the doctor now and not have to worry about, things. Maybe I'm worried I have cancer. I can go in and maybe, present as a stage 1 instead of a stage 3 or things like this. It started resonating with the American population when it really hadn't resonated before. So here in California, remember, many of the Obamacare architects came from California. And California, as a result, jumped in with both feet. And I still talk to my friends. I've worked for years with Peter Lee, the head of Covered California. And he was part of the Obamacare group that came from Sacramento. California became the flagship for the Affordable Care Act. And the result is that we saw probably a near 2/3 drop in the number of Californians without health insurance, just over maybe a 4 or 5 year period. Since 2010, certainly. Much of that is due to Medicaid expansion. We made Medicaid a program where you no longer had to have kids to be Medicaid eligible. If you're a poor single male, forget it. Historically, you couldn't be covered by Medicaid. Today, you can be. So California is a success story for the ACA, and here you see the reduction in uninsuredness rates in California. But things are not sunny anymore. You remember the sunny slide with the trees. This is basically where we're going. And the question is, what happens when the dog catches the car? Do we really want to go there in terms of repealing the Affordable Care Act? And this became really driven home. We started to look at numbers coming out of the Congressional Budget Office. Millions of Americans under various types of repeal and replace strategies were threatened with becoming uninsured. And you combine these numbers with the polling numbers for the ACA all of a sudden, and it became quite a poison pill politically in Congress. And the reason this is important is driven home by this. Gladiator, one of my favorite films. Joaquin Phoenix here in his star role. And I don't know if Roman emperors really did this with the gladiators, but John McCain stole this. So here he is, he's casting the last vote on what's called the skinny repeal of Obamacare. His name came up on the roll call earlier, and this is around 2 o'clock in the morning or something, and he kind of politically timed being in the restroom when his name came up for the first time. He walks back in and says, Mr. President Pro Tem, I'm back to cast my vote. His last vote on the floor, the deciding vote on the skinny repeal. And like Joaquin Phoenix, he basically said thumbs down. One of the most dramatic political scenes in recent times in American history. And the point is, the reason people are having trouble with this is that numbers like this start to come out. Now, these are all fairly large meta-analysis kind of analyses, not really cause and effect based. But the bottom line seems to be that if you're uninsured, you're much more likely to die. And by casting people off health insurance, it's very predictable that many people, many Americans, will die as a result. And that got to be kind of tough for people to agree to do. Thousands of people dying, not on my watch. And you saw, I think, if you were paying close attention to this, the revolt that went on, members of the Senate particularly basically saying, I just can't support this. I might be Republican, but I just can't support this type of thing. More information. 24,000 deaths are being avoided annually because of the ACA. More than are killed by firearms, HIV, and skin cancer. Again, this is an extrapolation based on Massachusetts data. And by the way, what was the first state? I can't help this. I'm a professor, so I like the Socratic teaching method. What was the first state in the United States to implement near universal health insurance? Wrong. Okay, you fell for it, right? Utah, Vermont, nope. Okay, I'll just get to this. Anybody gotten married recently? No? President Wilson, none of your students have been recently married. Okay. Obviously, they're very good students. We're working very hard. Brothers or sisters who just got married? No? Oh, wait, there's one in the back. Where did they go for their honeymoon? Hawaii. Hawaii, before Massachusetts, was the only state in the United States that had near universal health insurance. They required all employers to insure all employees. This is back, I think, in the early maybe the 1980s or so. A little kept secret, yes, sun, water, and health insurance. That's Hawaii. But in the meantime, the Obamacare Affordable Care Act has been taking some big hits. It hasn't been repealed, but it's basically being kind of wilted to death. The most recent change occurred when the tax penalty under tax reform for not having insurance was taken away. We had reductions in cost sharing reduction subsidies that states implemented. We're talking about how the marketplaces, like the exchanges, like Cover California, are failures. Most Californians would not agree with that, but maybe in other states. We now have these short-term health plans where you buy health insurance that lasts only 3 months, where they don't have to cover everything that's covered under the ACA. And things like this, especially the repeal of the individual mandate penalty, has led attorneys general in 20 states to sue the federal government to overturn the ACA because the individual mandate had been determined to be legal in the Supreme Court. So all this is going on as we move through the ACA. And the result is, again, my apologies for the fuzziness on the slide. We're seeing, just in the last few months, over 1 million more people in the United States without health insurance. And we just hope this trend is not going to continue, because we can be back very easily in the bad old days when a fifth of our population did not have health insurance. So I like to close on this last slide, and yes, I'm getting to the sailboat. Those of you who are waiting, getting to the sailboat. You can always count on Americans to do the right thing after they've tried everything else. Was that Winston Churchill? By the way, if you haven't seen The Darkest Hour, it's my favorite for the Oscar this year. The acting was splendid. Okay, I recommend you see it. No, this was Israeli politician Abba Eban talking about the United States in the Mideast. And not Winston Churchill, although this is typically attributed to him. Oh yes, here's the sailboat. So none of you are sailors, which surprises me. Nobody lives nobody from Laguna Beach or Newport Beach? Really? Okay. Anyway, that means I know more about sailing than you do, which is interesting. But the problem with sailboats is you can't sail directly into the wind. There's something called the dead zone. It's about a 90-degree angle, 45 degrees on either side of the wind, and you just can't trim your sails enough to make headway going into the dead zone. So what do you have to do? You have to tack back and forth and back and forth. And I think this is a good analogy for healthcare reform. So the United States is sailing into the headwinds, trying to achieve universal health insurance. But we can't get there directly. We have to tack back and forth because the headwinds are powerful. They're strong. Teddy Roosevelt couldn't do it. Franklin Roosevelt couldn't do it. Richard Nixon couldn't do it. Lyndon Johnson couldn't do it. The headwinds are that strong. 100 years of efforts without success. So we have to tack to the left, which might have been the single-payer ballot initiative in the state of California. And then we have to tack back to the right, which might be where we are today. And then we'll tack back to the left. I don't know how we'll do it. Maybe it's Medicare for all. And then we'll tack back to the right. But we'll be making headway down this path to universal health insurance. I'm being optimistic here, but there's a reality. Canadian Medicare, their universal health insurance system, took about 50 years to be achieved in the country of Canada. Started out with the province of Saskatchewan during the Great Depression, ended up in the 1980s. Finally, I think it was Ontario that was the last to implement physician outpatient health insurance in the country of Canada. I might be wrong about that. But it took Canada 50 years to do this. So things are very possible for the United States for us to achieve universal health insurance. And when we can do that, my request is that we take health insurance off the table. It's kind of embarrassing that we're still talking about this, and people becoming bankrupt because they're trying to get health care. That's an embarrassment for me. And we can talk about other things that, in my mind, are more important, like education, like making this country a happier place, like making sure that we can address other needs of the United States. Healthcare does not need to be front and center in the United States, and we need to eliminate that as a major social issue, because all the other industrialized nations have done so, and we can do so also. So that's my hope. I will close by one admonition, one request for all the students, because this is where it gets kind of personal. When you're seeing those patients that you see in your clinics, the outpatient center, for example, elsewhere, think about those patients that can't come in to see you because they don't have health insurance, because they're out there. And your job as healthcare practitioners, I would encourage you to be advocates to make sure that everybody can get health insurance, so that anybody, regardless of their station in life, can come in and see you as a healthcare professional. So with that, I'll close the lecture, and thank you all very much.
Thank you so much, Dr. Carlisle. Would you be willing to take a few questions?
Absolutely, absolutely. Dean Jones, thank you. Thank you for the invitation.
So, do we have questions in the back? Do we have some mics around by chance? Or is the only one? Yeah. Questions right here.
First, before a question, thank you, David. Very nicely done. I take to heart all of what you've said. I'm struck, though, in all of the discussions for the last 20, 30 years about health policy in the United States, that neither side of the aisle can get even to talk about what I think is a fundamental underlying issue, and that's the social determinants of disease and the social determinants of lack of insurance. As a psychiatrist and anthropologist, I'm struck by the secular trends in the lives of children in this country, and I think that's directly tied into downstream social problems, and including lack of insurance. And I'm struck by the lack of discussion politically about that issue. I just wonder if you have any thoughts about it, and also, again, thank you for that.
Yes, thank you. Thank you, President Wilson. 2 points. Cost. Cost of health care. As you see, it's out of control in the United States. It's what all the insurance companies are focusing on, trying to control cost. Yes, it's a major issue. Cost containment overtly was not part of the ACA, intentionally left out, because in order to get that majority vote in both houses, cost containment measures that might focus on the hospital industry, the insurance industry, the pharmaceutical industry, an intentional decision was made to leave those things off the table so that nobody would oppose the bill. And most of those industries lined up behind the bill, in large part because it had no cost containment strategies that were targeting specific industries. And this is very intentional. This is obviously a big issue for the United States. Social determinants. We have major opportunities to make the social fabric of American society better and stronger. And that's heavy lifting. I'm not sure what the solution to a lot of these social determinant challenges is. Low income, firearm deaths, things like this. That's complex. I'm a policy person, was up in Sacramento, but it was easy for me to talk about healthcare reform because I didn't have to talk about those more complex policy topics, social determinants. Right here in Pomona, downtown, huge numbers of uninsured, homeless individuals. Yes, we live with these challenges every day. It's much easier to talk about universal health insurance than it is to really tackle the elimination of the social determinants. I would say, let's put health insurance behind us so we can focus on the real challenges, social determinants of health, because they're actually a lot harder than making sure that everybody can pass the wallet biopsy. Thank you, President Wilson.
Good evening. Thank you so much for being here and opening up your world of knowledge to us and informing us on things that we really don't know about all the time. My name is Talise Morrow, publisher of the Inland Valley newspaper, located in the city of Upland. And my question to you is, when you talked about the sailboat going back and forth, how long do you think that we as a nation will be going back and forth before we can kind of get a definite plan for the universal health care for everybody?
If I could prognosticate that, maybe I could go into politics after I retire. Of course, I'm not planning to retire, so you don't have to worry about that. But yeah, we don't really know. I think we're closer to this tipping point than we've been historically. And I think this upswing of support for the ACA among Americans means that as Americans become more aware of this issue, the more they start to think about it as something that can be resolved. And I'm not sure what mechanism for resolution will finally manifest itself, but I think we're actually closer than we were 10 years ago. We're not where we need to be. We seem to be slipping backwards, but I think that backward slippage is, again, just a tack to the right. And it's like that, nuclear war clock that's ticking. We're actually closer to the midnight of universal health insurance in the United States than we've probably ever been in this country. I mean, we've got the ACA still in part, and I think that we can get there very, very, very quickly. We're probably closer than we know, and again, I don't know what it's going to be yet. It might be some variation of the ACA, it might be something totally replacing the ACA, but I think people are recognizing, again, that we're the only industrialized nation that does not have health insurance, universal health insurance, and this is exacting an economic penalty on us because these countries that are financing the universal health insurance systems with tax dollars, their industries have an economic advantage over our industry because the cost of health insurance for American employees is significantly higher than it is for other industrialized nations. Just to extrapolate, you've got Chrysler, before Fiat acquired them. They're building cars in Ontario and they're building cars in Michigan. The cars built in Ontario cost less to produce because of the cost of health insurance in Canada versus the cost of health insurance in the United States. You extrapolate that to Japan, Korea, that's a huge economic advantage that favors some of these massive industrial entities, and we need that advantage to be here favoring the United States, and this is one of the benefits of universal health insurance.
I think in the LA Times yesterday or the day before, today, there was an article on Medicare for All. And I thought it was an excellent article, and I think that's where the debate should begin. But I really think that the educating the public about that there's no free lunch for health, and been in California for 10 years, and I'm back in Texas now, and they were on that list for not participating. And what happens is they tax me for my property. And we have a county hospital tax, and I think I was paying like about $1,200 a year just to the county hospital. So whether it was Medicare, Medicaid, or the county hospital, somebody pays. And so I think that that's a major piece of that process. But I really think the Medicare for All is a good thing because it will allow everybody to participate, et cetera. Any thoughts on that? And to me, if we're we the people, we have to educate our patients about that process so that we can go vote. And I think that this whole, what's going on in America today is stimulating that. The governor of Texas is all concerned now. My wife voted yesterday in the primary. She said there were so many people out there, and they made her mad because she was voting in the Democratic primary. I mean, it was amazing. So she called me this morning to tell me about that. I'm sorry.
You know, we do have, for those of you who are single-payer advocates, most of you probably know that we do have single-payer systems in the United States already. One is Medicare, very analogous to health insurance in Canada. Another is Medicaid. And another is the VA system, more like socialized health care in countries like Great Britain and Sweden. You combine those three together, and you've got pretty much the majority of healthcare expenditures already in the United States, and you've got a lot of the population covered under those systems. So Medicare for All or Medicare Extra appeals to people because it's not that big a step from what we've already got. In fact, County Supervisor Sheila Kuehl, when she was up in Sacramento, I think may have been one of the first people to talk about Medicare for All. I mean, if it's good enough for your parents, or some of us here, it should be good for everyone, right? Lots of us look forward to getting to the age of 65 so we don't have to worry about this health insurance stuff anymore, because Medicare works very well for most people. It has its challenges also, but generally, by and large, it's a good health insurance system that pretty much allows people to see whoever they want to, anywhere they want to, for their health care.
Isn't part of that because Medicare is not for profit, and the part that's failing is the for-profit aspect of healthcare?
Yes, so this touches on the issue of cost and cost containment. There's something called administrative cost, which is a percent of the healthcare dollar that does not go for a direct provision of healthcare services. Generally speaking, in the private insurance world or the managed care world, that percentage, depending on the plan, can be as high as 20 or 25%. That's a big chunk of those premium dollars and a big reason why they're kind of high. Medicare, on the other hand, runs typically at about an administrative cost of about 4 or 5%. You put everybody on Medicare, and all of a sudden you're lowering cost. This became part of our calculus with the Schwarzenegger administration. We were trying to figure out how to explain increased spending for health care. And as it turns out, you mentioned people seeking health care and having to cover everybody. If you provide universal health insurance, the issue that's true today, I mean, when you and I who are insured go to the hospital, part of our bill goes to subsidize charges for people that are not insured who show up at the same hospital. We're paying for them. That money's coming from somewhere. It's coming from insured individuals. You take those uninsured people off the table, and the premium pressure on people that are insured goes down. And we calculated, I think, if I remember correctly, in Sacramento, that savings was about $1,400 per person. It's not a trivial amount of money.
We have two more questions. I believe there's one right here and there's one up at the top.
Thank you for giving me a chance to ask the question. I can talk to President Carlisle at any time, but...
And he does. I mean, he's our general counsel, and I hear from him all the time.
What worries me is this. Since the business case for universal health care is so obviously demonstrated, it concerns me that the United States is unable to put everything else aside and, in its own self-interest, pursue the business case that makes the most sense. That makes me think something's going on here that's not trying to find the best answer. And I think we're stuck. You talk about Sisyphus pushing that rock. We need to think about where we are as a nation, because this is the same kind of bankruptcy, in my opinion, that informs a lot of other things we're doing that's destroying the planet. You don't make money when everybody's dying. So I'm concerned. I think that the answer is pretty apparent. I just don't know why nobody can see it.
That's why he's a general counsel, because he's always making winning arguments. And fortunately, that wasn't a question, because I don't really have a good answer for it. I share the frustration.
Hold your hand. Yeah, there's a question up here. Well, there's one on the end, and then there's one right here.
Hello. Thank you for coming. We appreciate you being here. I just wanted to ask, what can we as future healthcare professionals be doing in order to get this sailboat moving a little bit faster?
Learn to sail. You're the first student to ask me a question, right? Now the other questions came from students, is that correct? I have something special for you. This is a CDU pen. Can you come down and receive it? In answer to your question, there are lots of organizations that have activist student members. The American Association of Medical Students, American Medical Student Association, congratulations. The Latino Medical Student Association, Student National Medical Association, the AMA, California Medical Association. They all have active student memberships, and I can just go on and on with across the different specialties. And the students are pushing the organizations to be more activist in pursuing the target of universal health insurance. And so that's a role for you. And students ask me all the time, how can I be more involved in policy discussions? And the answer is just to be more involved. I don't know what chapters you have here. You might have a chapter of an organization called Physicians for a National Health Program, for example. Look them up on the web if you want to. They're all looking for members. And it's the providers of the future who I think can catalyze this effort going forward. Because for you all, you see how important this is, I think, more so than other providers who are just working hard trying to make ends meet. So that inspiration, I think, can be quite infectious. And I would just say, go out there and be activist, and just think about, again, those patients that can't come to see you in your clinic or your office because they don't have health insurance.
We have one more question up at the top, and I think that'll do it for the night. Go ahead.
Thank you, Dr. Carlson, for coming. Just like the rest of the questioners, excellent.
You don't have to come up. I know it'd be kind of hard, but I'll get you later.
Okay. So my question is about what strategy would you advocate? I think like with requiring employers might decrease the ability for new small businesses to start, whereas like a single payer system would maybe stifle innovation for competition for larger contracts, and maybe you make it less personalized healthcare. So what do you think is like the best step forward?
I will answer the question in two ways, and we could talk about this for a while. The first is what I call policy by anecdote. So when I was up in Sacramento, my boss, Health and Human Services Secretary Kim Belshea, used to talk about people like me as the smarty pants. Because we were the people who always come into meetings with all this data and all these answers. We were like the technocrats. And we could be up there talking about this economic model and that. And then somebody would walk into a hearing with no data and tell an emotional story. Then all the members would resonate with that story, and they'd forget about all the data that we had. So think about important stories, like the member of the original Drifters, or like the young gentleman with the testicular cancer. It's those stories that really carry the day. That's one thing. Another answer, short answer, and some people will not like that I say this, you probably don't want to say single payer anymore, because people react viscerally against the term single payer. A viable alternative term is Medicare for all. Again, because that's what your parents have, that's what your grandparents have. People know about Medicare. And that's just one piece of advice. I know I've made some enemies saying that among people that are friends of mine, but that's part of the reality. Again, you can have a very strong policy-based argument, but if it's not politically salient, it can be the best solution to a social problem in the world, but it's irrelevant. Again, the ACA, healthcare costs are a big issue, obviously, but they had to take healthcare cost containment off the table to get the ACA passed. And it's that type of calculus that is driving policymakers. So think about important stories about people who suffer because they don't have health insurance. And those stories are always compelling, because that should not be happening in this country.
I could listen to you all night. I mean, this has been a phenomenal lecture. I appreciate this so much. Join me in a round of applause for Dr. Carlisle.
Thank you, thank you, thank you, thank you, thank you.
Just remember, now that you're a celebrity, I get 10%.
10%?
10%.
Okay, that means I get 10%. You get 10%. You get a whole pin, not 10% of a pin.
Okay, we have a couple of parting gifts for you, and I would like to invite the president and provost to come down to the stage, if you might. Possibly the president and vice president of the board. If you all come down, please.
I'll just say that I've already given the provost more CDU pins than he probably knows what to do with. So I'll make sure I'm giving one to the president. Gary, my apologies.
I have several of them.
Mr. President? And I think the board chair has also acquired a few CDU pins in the time that I've known him, but I'm not sure if the vice chair has. So Richard, please forgive me. I'll make it up to you.
Hi there.
Good to see you again. Good to see you again.
That was great, yes.
Okay.
Thanks.
All right.
So on behalf of the College of Podiatric Medicine and the University of Health Sciences, I'd like to present you with this little token of our appreciation. This is a little plaque.
Thank you. Thank you. Okay. This will occupy an esteemed place in my office, and I invite you all to come up to Charles R. Drew University to check out where the plaque is going to be in the president's office. I give great university tours, seriously. It beats hiring and firing and lawsuits. Even with our general counsel being the great guy that he is, this is what I enjoy the most. Thank you.
All right, so I guess we'll get a couple of pictures with everybody here.
Move over this way, this camera. Thank you. Why not? And move up a little bit because Dr.
So our head is cut off, right?
Bright light.
Oh yeah,
Step into the light.
look at your image.
This one?
Oh, we have to.
Yeah, see that one. Ow, here.
Still bright. Can you guys move up this? There we go. Right. There we go. Right there we go. Right there's good. Perfect. We're going to do 1, 2, and 3. Good. And look. Let's do one more, guys. 1, 2, and 3. Excellent.
Great.
Thank you. Okay.
Picture with
Another
Here. Richard. Okay.
Very good.
It's great to see you again.
I try to see how I can apply it in my own practice, and it's kind of like,
Yeah, it's hard.
yeah, it is.
It's hard to go there from here, always.
And they wanted to see, here's
Oh.
the other plaque.
Okay.
I'll hold this for you till the end of the evening.
Okay. Thank you, Margaret.
Association.
Yes,
This
yes.
is going to go in our office, so you're the third in line.
Okay. Okay.
We got to get one together.
Indeed. Indeed.
This will